everyone, I'm joined by Dr. Peter Kaiser here at COPHy. You're from the COPHy Institute. And I was mentioning before that at COPHy, there are a lot of people from the US that just have a little bit more experience with what's going on with aflibercept 8 milligram. That seems to be a consistent topic at COPHy. Could you maybe just give a little bit of your perspective?
Sure. So we've had 2 milligrams of aflibercept for many years, of course, about 10 years now, and the results with that drug are excellent. And more recently, the 8 milligram dose was approved in the US and now here in the EU also. And people just want to know, sort of, is it better? Does it really last longer? Because in clinical studies, you can design them to make a drug appear to last longer when in reality it doesn't. But with this drug, in our limited experience in the U.S., where we can actually use it as we want, the patients are doing very well. You know, so there's sort of two types of subgroup of patients that we use it. One are the patients who were doing, I wouldn't call it poorly, but we couldn't extend beyond 4-week intervals. And those patients were able to extend longer, 6, oftentimes 8 weeks and longer. So we're able to dry better with this drug. And then the second group of patients are those who are doing well on our current treatments, maybe every 12, 16-week intervals. And those patients, we can go even longer, 20, 24 weeks like they did in the clinical study. So both sides of that curve are important for the patients who we're talking about treating.
Yeah. And I think whenever you have something where you increase the dose, the topic of pharmacokinetics pops up, molar doses. And I think sometimes when that background isn't there, it might be confusing. Would you be able to kind of summarize how that kind of plays into maybe the efficacy that you're seeing?
Sure. So if everything stays equal, and in this case everything is equal, the drug is the same. If you increase the molar dose, you essentially increase the durability. It's based on half-life. So if you 4 times the dose, you double the half-life. But that's just in straight PK terms. Everybody else is going to be different. So in some patients, that increase in half-life will translate into several months of durability, excess durability. In others, that may be only several weeks, depending on their VEGF load. And that's why, when you look at a study, that's a population of patients. But in practice, you want to look at your individual patient in front of you, because everybody has a different amount of VEGF load that they need to have treated. And the beauty of using the high-dose Eylea is that you can figure out what that is using a treat and extend paradigm.
And we spoke to Dr. Kitchens about the at-home OCT. Mm-hmm. How do you kind of see that playing into also using, something like the aflibercept, any other drug as well?
So currently, if you look across the world, especially the United States, the usual paradigm for treatment is something called treat and extend, where you treat every time and then you decide what's the next interval, whether it's longer, the same, or shorter. And the reason we do that is because, in general, for us to follow a patient as needed, we would need to see them at least once a month. Whereas with treat and extend, you can go 12, 16, 20 weeks between visits. With home OCT, we'll be able to do that type of as-needed treatment, which is probably better to do it that way. But in the past, we just didn't know when the patient was leaking, and so we erred on the side of safety. If we have home OCT, especially with some of the machine learning algorithms to tell us when the patient's actually leaking and requires treatment, we can really just deliver the drug when we have to.
Yeah.
And that will probably be better for the patient also.
And so would that be something where a patient is given an injection and then the next interval is kind of left in the air, and then based off the leakage, they'd be brought in and triaged accordingly?
Yeah, exactly. Yeah. So in that case, we literally, they'll have the home OCT, and we'll receive an alert basically telling us this patient needs to be seen. And then we bring them back for the treatment. So we'll basically say to the patient, we'll see you when we see you.
Yeah.
Basically, when you need the treatment, we'll get you back here.
And here at COPHy, it's very much a debate-style conference, and so there's been talk about anti-VEGF, a lot about AI, GA. Is there one topic in particular that kind of got you, I don't know, maybe thinking a little bit more and humming and hawing?
I think you mentioned home OCT. There was a good debate about, how much our biomarkers, artificial intelligence, et cetera, are going to be how we do things in the future versus the way we do it in clinical studies, which is much more of a fixed or rote protocol in terms of treatment. And my feeling is that in the future, we are going to be using machine learning. We're going to be using a lot of the biomarkers that maybe we can't see at baseline will predict how a patient's going to do long term, maybe how many injections even they'll require, which currently we have no idea.
Yeah.
So that's exciting for the future.
Nice. And then the last one I just wanted to ask about was more of the safety conversation. I think currently it's a little bit more of a topic because of, iritis or any uveitis or endophthalmitis kind of discussions or vasculitis. Is there a thought that you have in terms of injections, kind of a statement to kind of summarize? We talked about IOP as well in some of the debates.
Yeah, I think, different drugs have different side effects. With the high-dose Eylea, we haven't seen any retinal vasculitis, retinal occlusive vasculitis. It doesn't mean in the real world we're not going to. We'll certainly be looking for it. We did have an anti-VEGF agent in the past that had a very high rate, actually two. One did not get approved and one did. And so as retina specialists, we're really in tune to look for inflammation. Endophthalmitis, unfortunately, is related to the injection. The more injections you do, the higher the rate will be. It's a low rate to begin with, but certainly any drug that extends the interval between those injections will lower it by definition. So we'll see if this lowers it over time or not.
Perfect. Thank you so much. And thank you everyone for tuning in. We'll see you next time.
ClinicianLink.ai